You're watching the Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, minimally invasive back surgery. We're talking about endoscopic spine surgery. With us, we have an expert on the topic. He's performed over 8,000 of these procedures. Very few doctors in America are doing this approach when addressing the spine. So neck pain, back pain, leg pain, you may be a candidate. With us, we have Dr. Mork. Dr. Mork, welcome to the program.
Thank you.
Okay, so you've done 8,000 of the procedures that we're about to talk about.
That's correct.
So are you an orthopedic surgeon, a spine surgeon? What do they call you?
Yes, I'm a board-certified orthopedic surgeon.
Okay.
And then I have a special interest in spine surgery. So I've been operating, over the past 14 years exclusively on spine, and have done about 8,000 procedures, including lumbar spine, thoracic spine, and neck.
Now, at the top of the show, I talk about new breakthroughs, new technology. I mean, this is fairly new. Not a lot of people doing what you're doing. And I have a lot of questions about this. I'm calling it minimally invasive endoscopic spine surgery. Is that what it is?
Yes.
Okay.
Yes, and the reason being that's where I lived. I mean, I was an arthroscopic surgeon. So in most training, spine training kind of programs, I mean, they don't really emphasize arthroscopy because that's not what most people are doing.
And arthroscopy is a scope, learning to do surgeries with a scope.
Correct. So you're using a scope, just like the knee scopes. And prior to that, of course, they made large incisions on, just people's knees and shoulders. And then they had to do open type of surgery, where you're letting the lights from the room come into the wound, and it was a larger incision, a more soft tissue disturbance, etc. So I thought, but I was there at that point in time when they transitioned to arthroscopy for orthopedics. And then when I had done that for a while and was in a big spine office watching surgical procedures all the time, I said, well, why aren't we doing arthroscopy on the spine? And at that point, I decided that, yes, maybe that was a good idea. And for the last 14 years, that's all I've been doing.
Now, so we can establish this. I want to make sure that I have this right. By the time they get to you, they pretty much know that their own medical doctor knows that the pain originator is a nerve. Something is hitting the nerve. Is that right?
Yes.
So you could either, and they've tried chiropractic and everything else, and anti-inflammatories and medications, narcotics. And so now that surgery is an option, what are the surgical options, and what is it that you're doing that's different than traditional spine surgery?
Well, the main thing is the actual size. The concept for spinal surgery is really one of two kind of concepts. One, you're going to fuse somebody, and that you're going to weld, a couple portions of the spine together.
Really? Okay.
Yeah, so you're going to make it solid, either with bone grafting or implants or rods and screws. You're going to somehow take the motion out of that segment of the spine.
So by taking away the motion, it doesn't hit that nerve and the person doesn't feel the pain.
That's
right?
That's okay. The concept.
All right.
Whether it works always like that or not is not always the case, but that's the concept.
You refuse to fuse, by the way.
That's right. That's my tagline.
That's your line. Did you come up with that on your own, or?
Yeah, actually, I did.
Refuse to fuse.
I did.
Okay.
And looking upon it, I noticed that other people had said it, but I just came up with that at one point.
And here in the U.S., you say that there's about 300,000 fusions that are being done a year?
Yes. And
if they got to you early enough, you might be able to wipe all of those out. I don't want to put words in your mouth.
Right.
But if they got to you early enough, do you think?
Yes. I actually believe that if I see people early enough, that probably 70 to 75, maybe even 80% of people could avoid what would be typically go on to be fused.
Okay. And so the options now. Okay, so they can't get rid of their pain. They've tried everything. Their doctor has told them you may need spine surgery. So what are the surgical options? That's what I really want to know.
Right. So the surgical options are mainly, it depends a little bit on what you're operating on. Let's take a disc, for example, whether it's a cervical disc or a lumbar disc. The idea is that we want to go ahead and decompress the disc, or to take the bulge or the bump out of it. So how do we do this? Well, we can actually go through the back and through a little bit larger incision, maybe even using a larger tube. This may be a tube the size of a quarter or 50-cent piece. You can go through the back and move the spinal cord to the side and actually take the disc fragment out.
Okay.
Or in my case, I can use a tube that's about 4.5 millimeters, just traverse certain areas of the spine that do not require any bone removal and actually enter the disc.
What does that mean, traverse areas of the spine?
To go through, to actually just...
So you go through the spine and what? Remove some of the bony tissue to take the pressure off the...
Well, you got to go through the skin.
Okay.
And then you got to go through the muscles. And the idea is that you don't want to disturb the muscles and ligaments and soft tissues before you get into the disc. And you don't want to be bumping into the nerves or the spinal cord either. So if you can make a direct shot with a very small tube into the area, the abnormality, the small area. The problem with the spine surgery is that you have to make a big approach oftentimes to solve a small problem.
Okay.
So this
Meaning
is,
you got to open it up.
That's correct.
Okay.
So in this situation, we're using a very small tube to approach the problem directly. And it's a small tube, you know, it's a big magnification power, 22 magnification, and a light source.
And you're doing the surgery on a TV.
Correct. So so the little bit the arthroscopic skill set, which is a little bit unusual in spine surgery, is that your hands are working down here, and yet you're watching a screen, a monitor, on the wall or floating from the ceiling. And so you're able to do it. And actually, to give you a little sense of it, sometimes like in disc surgery, for example, safety is increased. The surgery is so minor that you can do it when people are under conscious sedation.
Is there an ideal candidate for this particular procedure? And it's just called endoscopic spine surgery.
Yes.
So that's what they should look for, endoscopic spine surgeon.
Yes.
You say there's only a few in California.
Right. There's one other, to have a dedicated practice, I think there's only one other guy in Los Angeles that I'm aware of.
Is it true that after your surgical procedures, these endoscopic spine surgery procedures, people with back pain, neck pain, sciatica, after you're done, that they can walk out?
Yes.
And the scarring is what? What does that look like?
Well, the scarring is minimal. Scientifically, it's been proven that the amount of scar tissue generated is directly proportional to the size of the incision. So if I'm using a quarter-inch incision or half-inch incision, of course, the amount of scar tissue performed is proportionately less than if you're using an incision of an inch or inch and a half or 2 inches.
Okay, now let's talk a little bit about results. So people that have been suffering with back pain, neck pain, sciatica, they were told you need a fusion, you need this, you need that. Have you had people that have had 100% turnaround? 100%.
Just for example, I was taking care of a doc from Colorado. He had actually a disc herniation, severe one in his low back, L5S1. He had tremendous back pain and leg pain, and he was no longer able to function as a doctor. He absolutely refused to have a fusion. And this was back...
Was he told he might need a fusion?
Oh, he was told he needed a fusion. He needed a discectomy, well, at least a discectomy, possibly a fusion. It was 50-50. One group told me he needed just the discectomy. The other group told me he needed a discectomy and a fusion. So it was a split vote in his locale.
And he heard about Dr. Mork.
Yeah, he said, well, I can't do it. He couldn't work. His sleeping, he couldn't sleep. He couldn't work. He was miserable. And but he kind of loped along and he just said, well, if I wait long enough, somebody's going to come up with the technology to be able to do an endoscopic procedure.
Okay.
And that was probably in maybe the mid-2000s. And he came down, saw him. He actually left pain-free, the clinic pain-free, went down to the beach. When I was in Florida, he went down to the beach and actually just started his recovery there. He was back to work within 1 month, and he's actually been a friend and a strong referral source ever since.
So how does it stack up against, that means what you're doing, this endoscopic spine surgery, minimally invasive, how does it stack up against other back surgeries like fusion?
I think it actually is as good or better.
Okay.
And better in certain ways.
What about the literature? What does that say?
The literature is all over the place. So it depends on what paper you read. It depends on what aspect of the surgery you're talking about. I'll give you an example. If we talk about fusion success, are we just talking about the fact that the fusion took? In other words, that the bone actually welded together?
Okay.
Because that's a definition.
That's one statistic.
Yeah.
Okay.
Now the pain might be still present. The person might still be miserable. But if you define your success as just
did it work?
Did the fusion work? Well, yes, it did, or no,
but
it
pain.
didn't.
Let's talk. Okay. So are there any studies out there about patients reporting pain going away?
Yes. And they're all over the board. There's studies for fusions that show that it's as low as 45% of the people actually benefited from the fusion, and then if you go up in for the lumbar, it might be even into the upper 60s and 70%. What I call good to excellent results.
Okay, and what you're doing How does it fit in there?
Yeah.
In those ranges?
So probably there's more than one problem. As we said, there's more than a few moving parts in the back. You've got disc problems. And for a disc problem, for example, sometimes that's treated with a fusion and sometimes not. But in our literature, Dr. Tony Young in the year 2002 did a paper of several hundred patients and had 80% good to excellent results with absolutely the minimum of complications.
Using the technique that you're
Yes.
doing.
Yes.
Now, there's problems with fusions, right?
Yes, there are.
Like?
Well, there's the short-term kind of problems, and there's also some longer-term problems. So, of course, with a fusion, you have you have problems such as bleeding, dural leaks, deep venous thrombosis in your legs due to the prolonged anesthesia. So you've got several kind of short-term complications that can occur.
So you're just going in and basically removing the area that's hitting the nerve.
That's correct.
Through small incisions, what, 2 incisions, 3 incisions?
Just one.
1 incision.
Yeah.
Now, logically, it sounds like, okay, so if it's as good as you say it is, you're a board-certified orthopedic surgeon, why aren't all orthopedic surgeons doing it this way?
Well, there's probably a couple reasons.
Without being too politically correct, as we say.
Oh, okay. Well, one is just simply the exposure to arthroscopy. In other words, if you hadn't had a lot of arthroscopic training, the whole thing might feel a little bit clumsy to you. You'd have to take some time off.
Now, you said, when we talked on the phone, you said, I'd love to see more necks in my office.
Right.
You could help those people the most, people with really chronic neck problems.
Right.
Why is that?
It's just, well, the real fact of the matter is it's because the head is fairly lightweight. It only weighs about 8 to 10 pounds. So a typical problem, in the cervical spine is foraminal stenosis. And people end up getting neck and shoulder and arm pain. And the stenosis can be bony or it can be from a disc. But as
stenosis means that canal is closing in with like a calcification or something like that?
Right. Imagine with time, as the disc spaces naturally diminish and collapse, that the little canals that they also border are also collapsing.
So when you bend and move, the bone hits that nerve and it hurts?
Correct.
Okay.
And also what most people don't think about is the fact that some people have just large nerves. So that it's not just a matter of a standard size. Yeah, so you can have large nerves, and so even one that looks like you've got a fairly normal size canal can actually be compromising a large nerve.
So would you say there's tens of thousands of people throughout California, you have a Newport Beach practice, that are suffering that don't have to be?
I would say that's the answer, yes.
Really?
Yes, and yet they're not suffering to the point that they'd contemplate something big like a fusion. But something like this as an outpatient procedure could be just a lifesaver, give people back their life.
So why is what you're doing better? If you could dummy it down for me a little bit.
It's better because there's just less of it. I mean, in surgery, in my opinion, less is more. And I refuse to fuse, so I'm trying to maintain people's motion. I'm trying to do it through a very small incision, through areas that are not going to compromise or create more problems for people.
Okay.
The complication rate's incredibly low, since oftentimes you can do this under conscious sedation. Blood loss is almost negligible. I'll just give you an example. This is a guy who's had back pain since he's been a teenager, and he's now, I think he's 47 or 48. Very active in martial arts and a scuba diver. So he's a scuba instructor, martial arts. He's had pain since he's been a teenager's back. About maybe 7 or 8 years ago, he actually had a fusion, L5S1, which was practically guaranteed to help him with his low back pain.
Okay.
I saw him, and if I'm ever confused about any particular pain or problem, I go through what I call a spinal diagnostic evaluation, or pain mapping.
Okay.
So in this particular case, I took him to the operating room. He's perfectly awake. Find the area of pain, inject a little local anesthesia, let him get up and walk around the operating room. He's 100% pain-free. So there, I know I've got the problem figured out. So it turns out that this fella, who had actually had a lumbar fusion for back pain, really had just a soft tissue problem, a ligament and tendon kind of issue, that when treated with the laser, he actually woke up the next day completely pain-free. I've seen him now a couple times in the office afterward, and he's got no return of his pain whatsoever. So he ended up having a big operation that was not really, duress. So I think that when you're using endoscopic spinal surgery, it's a part of the mentality that goes with it that you are a little bit more conscientious of trying to determine
Okay.
where the pain is coming from before you operate on it.
Now, you told me something on the phone, and I said, and I was thinking, because I try not to endorse you, and this is not an endorsement for you,
Yeah.
but if what you're saying is true, and I'm not an expert on this topic, could critics, by the way, argue with what you're saying?
I guess.
Could they?
Sure.
And what would they say?
Well, they would just say that it's,
Like experimental?
sure, that because anything with the laser is experimental, or that you've done too many of these. This is not a talent that's applicable to everybody in the community.
Okay, because you've done 8,000
Right.
plus.
I've done a lot of these, so I have a certain kind of a routine, an algorithm, so to speak, of trying to identify where people's pain is located, and also and having found it enough times, I can go back and oftentimes relieve the pain situation for people.
Now, go ahead.
I'll give you one more. And they also, I think when you use endoscopic spinal techniques, you are sometimes limited by how many levels you can address. So if someone's got multi-level issues, sometimes I can't fix them all at the same time. So it would require a second sitting.
You say that in some cases you're giving people their life back.
Right.
Elaborate on that.
Well, chronic pain will change everything in your whole life. It starts slowly, and there's that funny saying that, if you weren't crazy, before you had chronic pain can drive you crazy.
All right.
It'll drive you, to depression. You can't sleep, so you get to be a little edgy. When you get to be a little edgy, your family and your relationships start to suffer. You can't pick things up. You can't play sports. You can't exercise. Your weight can go up. Your whole life is really affected by chronic pain.
Do you think people are afraid of surgery? That means people that are tuning into this show, because we're talking about endoscopic spine surgery, minimally invasive, that people after the surgery walk out of there. Is that right?
Yes.
Okay, but do you think people, and also we're talking about a free consultation with a free MRI, and you'll let them know if they're candidates or not. But my question is, do you think just because of the fact that they hear this is a board certified orthopedic surgeon, he's thinking surgery, surgery is really the end stage?
Right. Well, first of all, about the free MRI, I'll look at the MRI, but
I see. Okay.
I don't
so
provide
once
an
they
MRI.
have an MRI, you'll
Yeah.
look at the
Yeah.
MRI,
Yeah.
but you'll do a free consultation.
Yes, I'll do that. But as far as the surgery goes, it's a lot less. It just happens to be a lot less because oftentimes the spine problems that cause tremendous pain. Okay, think of this. Think if you're out in the garden and you're working on your rose bushes, and all of a sudden you get a little thorn in your thumb, and your total attention is riveted on that pain in your thumb.
Okay.
And then you get in the house, you say, well, geez, I got to try to find this. And you look at it, you say, I don't really see anything. You get a magnifying glass. You can barely find the thing. It doesn't take very much sometimes to cause a lot of pain for people. And that's been my experience with spine surgery. We're oftentimes chasing a very small thing. So if you have proper lighting, proper magnification at the end of a very small scope that you can actually get some instruments through, maybe that's all people really need to do. And then it's not such a big deal to be getting. I mean, I don't want to diminish the fact that it's spine surgery, but I also want to say that surgery itself doesn't have to be such a big deal.
So you see transformations, would you say, every week, every month, that are what some people may call a miracle story, or at least to the patient, that's diminished pain, or they could sleep, or they could function, or go back to work. It's big.
It's big. I had a guy, and it's big at both ends of the spectrum. The older group, the people who are in their sometimes 80s and 90s, they'll be refused standard surgery. They might be in a wheelchair because they got back pain, or they just can't get around.
Have you ever had that happen?
Oh, sure. I've had people that have been referred, older people in their 80s, either referred because they were medically unfit to have a big spine operation. So the local spine doctors just passed on them. They said, well, we can't do anything.
Nothing you could do.
Nothing we can do because the operation will knock you off. It'll kill you. And they said, well, we're not going to expose ourselves to that kind of risk. So they came down for an outpatient procedure with minimal blood loss, and sometimes actually was able to completely eliminate their back pain. I still have their son, now that fella passed after a couple of years, but I still treat his sons who are now, they're probably in their 60s and 70s.
But you've had
now.
a person that's actually been in a wheelchair that's no longer in a wheelchair. And they were in a wheelchair because they couldn't handle the pain.
Correct. And no one would treat them because they were too old or they had too significant of a medical condition.
So with what you're doing, you could be in your 80s. You could have a little bit of diabetes. You could have some of these problems.
You could be a smoker. I mean, smoking is one of the biggest reasons that fusions don't work well.
You know, I interviewed a pain management physician. He told me one time, people are under-medicated. Meaning you can't, he said, all I do is pain so I can manage the medications.
Right.
Do you think people are under, I don't know the word for it, but they're not getting this option given to them enough?
Right, because
Surgery.
there's so few people that are doing it. In other words, most surgery is fairly dramatic, and so that's why it's not really recommended. But the thing is, I actually advocate, pain management is fine, but I don't want to manage pain, I want to cure it.
You want to cure pain?
Yeah, so that's my thing. I want to cure the pain, and these procedures put me into the position of being able to cure it.
And by the way, does it work better, this technique, and we're out of time, better for the neck, better for the back, better for sciatica? Is there a particular kind of pain that it works best for?
I would say that if you were to look at things statistically, all problems, discs, stenosis, that neck surgery works better because there's less weight going across the cervical spine.
But early treatment is better, always.
Well, not too early. You've got to let people get through their conservative treatment time frame. But after that, it just depends on what you're going to tolerate and what you're willing to.
Okay, so they've tried everything else. The pain's not going away. They know it's nerve pain. So what should they look for in an endoscopic surgeon?
I think that you should ask the person, are they board certified? Just check out their basic references. Second thing is, how many of these cases have they performed? Have they written any papers?
You've written about 11, is that right?
Yes, I have 11 either authored or co-authored 11 published papers. Okay. Do they use the laser? I mean, do they have access to the laser?
How often do you use the laser?
Yeah, how often do you use the laser?
How often do you use it?
I have a laser present really on every case. Now, I don't always use it. For the bony type of cases, you don't have to use it as often. Sometimes for the disc cases, you don't need it. But when it's appropriate, you want to be sure to have it around.
Okay, so ask if they, how many endoscopic spine surgeries have they done?
Yes.
Because that's a tough question to ask, by the way.
Yes.
It's almost insulting, I think, to ask a doctor, how many of these have you done?
Yeah, but
could you? Because you've done 8,000.
I would. So I'm happy to tell you. But it would be nerve-wracking for me to tell somebody I've only done 25 or 30.
Have you done more than just about anybody?
I'm probably pretty close.
Is that right?
Yeah. I'm sure there's people who've done with a few more, but I certainly that's a.
You're the top 5% in the world, maybe.
Of endoscopic spinal surgeons, probably only less than 1% of spinal surgeons are endoscopic spinal surgeons, and so if you take the top 5% of that group, you're talking about a pretty small group of people.
Is that right? Yeah. So because people can walk out of the surgery, you have somebody drive them home.
Yes.
Okay.
Or to a hotel.
But they could fly in
because they come from elsewhere, and then they go to a hotel.
And when do they have to see you again?
Well, at the hotel, I will see them the next day.
But they could stay in town for 3 or 4 days, or you
they
want
do.
them to stay in
I
town
recommend
for
that they stay in for a couple, 2-3 days before they take off.
Okay. What do you like most about what you do?
Well, it's just I get to see people who've got a difficult problem, that their lives are being significantly impacted, and with absolutely the minimal treatment, the minimal invasion into their lives, I can oftentimes solve their pain problem.
And you have miracle stories every month, every week. Are you ever surprised at the results?
I am. I am. It still surprises me that I can do it, even to this point in time. I still, sometimes I'm amazed. I'll just tell you one that I saw last summer. This was a gal who was 45 years old. She was a teacher up in the San Luis Obispo area. She came in, she was miserable. She has to stand. She's a grade school teacher, loved her job. She and her husband, just a great couple. But obviously this back pain business was giving her a big problem. She was no longer able to stand for the whole classroom, and she was going to have to retire. Last summer that was it. She's a do or die. So she came in.
Was she already told she needed surgery from someone else?
They want to do a 3-level fusion. I think
that's like welding the spine together.
Right.
Okay.
I think they want to do a 2 or 3 level fusion. But her disc spaces were intact. I said, okay, well, let's figure out where your back pain's coming from. So I went through that process, the diagnostic or the spinal pain mapping, discovered the discs that were really causing her pain. And they weren't all causing the pain, but just I think 2 or 3 of them were. So, and she had some leg pain that was going with this as well. If it was just pure back pain, I probably wouldn't have done this. But the leg pain, that tipped the scales for me to do this. I did this, let her go back to the hotel.
How long does it take you to do, by the way?
It's about 2 hours.
2 hours to do.
Yeah,
okay.
she was conscious.
She goes back to the hotel.
Yep, back to the hotel. I went to see her the next day, and she actually she rolled around. I said, "How you doing?" She said, "Well, I got surgical back pain," but she said that deep, horrible back pain that I always would have is gone. And I said, "Well, let's see how it goes in a couple more days." And so she got up and walked around. I saw her a couple days later, and that deep, horrible back pain was gone. And then I said, well, let's go on home and let me know how it is in 4 to 6 weeks, and we'll talk about it. Well, she only had about 8 weeks to decide. I think she had 6 weeks to decide about going back to school, and in 8 weeks she had to go back to school. And she called me and she just said, I want you to know that I'm back to school full duty. I have absolutely negligible back pain. I'm perfectly functioning like I used to. And they write me cards at all the holidays, and she and her husband were so excited because their personal life had been returned back to normal as well.
That's good.
Oh, it was, sometimes it really turns out great like that.
So endoscopic spine surgery, find out more. They can call your office. They can get an appointment on the phone. You'll talk to people on the phone? Or it's all face-to-face, especially if they're coming from out of state. You could talk to them. They could send you an MRI. You can look at it. Tell them if you could help them.
Yes. So oftentimes, if people are from a distance, they can, of course, send things in. I can talk to them on the phone if they want to just talk about it. If they're close by, sometimes they'll just make an appointment. They'll bring their films in, but I'm happy to do it either way.
I want to thank you for coming to the show. Great
Thank you
info.
very much.
And this is on your website. They can look you up and find out more about the procedures you're doing.
Yes.
You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you'd like to find out more, or if you missed the first part of this interview, I suggest you watch the whole thing. You can go to wellnesshour.com, put in spine surgery, endoscopic spine surgery, or you could put in, it's very easy to remember, Dr. Mork. You'll find him there. For now, I wish you could help.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.